final. However, I will tell you that, if you can be here Wednesday, that's where the bulk of the questions will be coming from for your next exam and final. Why? Because that is material that you're going to see on NCLEX, okay? So that's how I kind of lined this up and laid it out for you. Psychosocial material on NCLEX will be, you can have 6% or you can have up to 12%. And I'm going to give you some information today about those horrible, as my seniors say, therapeutic communication questions. They are so subjective, yes, but with some strategies, you will get better at it. And it just takes practice, okay? So I'm going to give you some information about that today, too, so that should hopefully help you. But again, the PowerPoints are up, okay? So you can look at those. We're starting, theory-wise, it's chapter 24, okay? That's the one we're starting with. And again, I put this up on Blackboard. Next Wednesday, it's chapter 19, okay? So that's what we're looking at. Okay, so as I looked at this material, I wanted to let you know that first of all, when we talk about aggression and violence, we also have to talk about anger, okay? So maybe some of you hit the table and said, dang, I should have answered that. Or maybe some of you went out and you my point being, that's actually healthy, okay? You want your patients, your coworkers to verbalize anger, okay? And what you'll find a lot in healthcare is that your patient wants you to listen. Listen to what I'm saying, okay? So, when does this become a problem, okay? We have patients, we have nurses, we have physicians that can actually become aggressive. Aggression lends toward a hostile environment, okay? And I put up an article. It's an easy-to-read article, but it's a great eye-opener about hostile working environments in healthcare. Who's affected the most? Healthcare workers, social workers, as far as hostile environments, hostile working environments. Social workers. And healthcare workers. So, my question to you is this: how do we handle an aggressive or violent patient? Do you think it's not going to happen? Oh, it'll happen. Okay? Because you think these people are only in the psych loony bin? Oh, no. They're everywhere. Everywhere. Okay? So, you're going to encounter this, okay? Now, if you learn nothing, when you see priority, you better look at safety. And I'm talking about safety as far as it's called risk for self-directed or other directed harm. You have a responsibility to keep that patient safe. You also have a right to not be hit or spit at or scratched, pushed down. Okay? So that is priority in this situation. So when you see priority, you are going to say safety. So that means you're not going to commit suicide. And that means they're not going to hurt themselves, and that means they're not going to hurt anyone else in this environment. Okay? And I'm going to try to teach you how to handle this because there are certain things that we want to do. I will tell you, theoretically, restraints are the last resort. Theoretically, right? You guys got me? Theoretically. Okay, they are the last resort. So, first of all, as nurses, we have to identify who's at risk. Who's at risk for aggressive, violent behavior? First of all, a past history of violence. Okay? When my patient's family is the gang, and they're in the hospital because they've had a stab wound to their chest, that patient is at risk for violent behavior, right? Okay? Also, childhood aggression. They set fires. They torture animals. I could not believe, I was reading the Charlotte Observer, okay? What's wrong with this picture? The mother writes in to that psychologist, it's in the paper. And she says, my son, I found him, he was setting fire to this mice, and then the others, he was drowning them slowly, and then the other one, he was cutting them up into little pieces. And the mom says, is this normal? I mean, what's wrong with this picture? Is this normal? No. That is aggression. That is violent behavior. And because the boy just said, well, they're only mice. Well, they're only mice now. So, you're like, oh, man. So, yeah, but the mom says, is this normal? Oh, really? Okay. Substance abuse. You will find also mental health disorders. When you have substance abuse and a mental health disorder, that is called a dual diagnosis. Okay? Now, I will tell you that when you have dual diagnosis, and I used to take students to the Charlotte jail. Well, we not only have dual diagnosis, we now have prison time. Okay? So, that is what that means. So, substance abuse, mental health disorders, disorders such as major depression, schizophrenia, bipolar. Okay? These in particular can lead to aggressive or violent behavior. Okay? Schizophrenia are the ones that you can hallucinate. Okay? A family member sets fire to the house because voices from the refrigerator are telling her to set fire to the curtains. Okay? With bipolar is where you have the extreme mania. Okay, and I'm not talking hyperactivity. Okay, I'm talking manic behaviors. And of course, with depression, I think we all can understand what's to live for, right? What do I live for if I'm depressed? Huh?
Sleeping a lot.
Sleeping a lot? Don't eat. And so what happens to you? Commit suicide. Commit suicide. So again, it's self-directed or other-directed harm. Okay? Others, males, young males are our risk takers. They have a greater statistical number as far as violent behavior. Also, lower socioeconomic status. They don't have the resources. They may have family breakdowns. Like I said, when your family throws you out of the house, calls you stupid, you can't do anything right, well, that gang becomes family because they accept you. The more drugs you do, the better they like you. The more people you hurt, the better they like you. And gangs are everywhere, right? They're everywhere. So, those are some of our greater risk patients. Again, guys, they're not in the psych loony bin. There's some there, obviously, but they're everywhere throughout the hospital. Okay? We deal with them on a weekly basis at IMC, as Kayla will let you know, because I see Kayla almost every week. So they're everywhere. They're in pretty much every area you can think of. So, the big question, what are you going to do about it? Say, oh, you're just a bad person. Why are you doing this? Are you crazy? That's going to get you, because that's going to set them off. Okay, so what are we going to do? First of all, safety is our number one priority. Okay, and I cannot say that enough. Okay, those are your priorities when you're dealing with these types of patients. Okay, so what are we going to do? It's called, theory-wise, it's called de-escalation techniques. De-escalation. De-escalate. Okay, so we got to bring this person down. Okay? Now, I will tell you, it can be very frightening when a patient is in your face. Well, let's look. What do they look like? Okay, maybe they look. Do they look tense? Yeah, says eyes. Tense, anxious, agitated, possibly pacing. Heart rate and blood pressure are elevated. Voices raised. Threatening. Okay. So, this is the person, this is your patient now that you're dealing with, okay? And sometimes, in fact, last week Kayla said to me, he was so mean to me. They can be mean. They can be very mean. But I will tell you that unless you are doing something horribly wrong, it's not about you. It's about them. Because, one, especially when they're in the hospital, you have stripped them of drugs, of control, of their families, the gangs, or whoever. You have taken that away. And they get angry, and they'll get aggressive, okay? So, de-escalation techniques. I cannot tell you you need to be calm, okay? You need to have an open posture. You need to try, no one, in fact, this is something I never liked about teaching, is I feel like I'm here and you're down there. See, that sends the wrong message to a patient. A lot of patients you need to get down to where they sense now that you are listening, that my attention, my sole attention is now what you're doing. You're giving me that. Get them to verbalize their anger. Okay? Miss Jones, I see that you are angry. Let's go and talk about this. sometimes, like I said, they just want to be heard. Not, I'll be back. I'll be back just a minute. I called you an hour ago. Why isn't anybody come in this room? I don't blame them. Do you blame them? Sometimes I don't blame them, you know? But just as you hit a table or you go out and start running your mouth with somebody or whatever, you don't take it to that level of, I'm going to hit you. You know, when they get to that point, it's like, you better get here and do something or somebody's going to pay for this. You're crossing a line now, okay? So, and I'm going to show you some little tidbits about these therapeutic techniques, okay? Guys, make sure, be very careful. You need adequate people around you if they are becoming hostile. Okay? You want adequate people around you. This is not the time to go in a room and close the door. You want adequate people around you. Okay? Also, if they continue to escalate this hostile behavior, you need to set limits. You need to tell them what's going to happen. So, Mr. Smith, if you continue to try and hit me, I'm going to have to give you an injection to calm you down. Mr. Smith, if you continue to try and hit me, you will be restrained. Let them know the consequences of escalating to that hostile behavior, okay? They can't cross that line. Why? It's a safety issue, okay? It's not safe for them. If I've got a man kicking and hollering and screaming, all I see is a foot going in a side rail, being cut, you know, knocking, oh, he's going to fracture his arm, hitting the back. I mean, it's a safety issue. Not only can he hurt me, he's going to hurt himself. So once you have set the limit and they violate that, they know the consequences, and you must do that. You must then do something, okay? Guys, I will tell you some of the meds we use are your antipsychotics. You can give them IM. Haldol is a biggie. Okay, Haldol. Other ones are Risperdal and Zyprexa. And there are others. The one that I see used the most is Haldol. Okay, they're antipsychotic. We also will give Ativan, a benzodiazepine, if they are aggressive. Okay. And the last, we will restrain them. And we will 4-point restraint if it is necessary. Okay? Now, I can't tell you enough, when you start dealing with patients in restraints, and maybe you already have, you better know your hospital's policy, okay? Because you must address either every hour or every 2 hours pain, pati, circulation, food, water, nutrition. Why? If you remember, or maybe you're too young to remember, way back, people died in restraints. Okay? And these medications have really helped to cut down on the use of restraints. I mean, I would rather hold you down, give you Haldol and Ativan, and you go, than put you in 4-point restraints. Okay, I would rather do that. Now, if I have to put you in 4-point restraints, you're not coming out of there until your behavior has changed. You take the restraint off, 1, and you watch them. You watch them, okay? You don't just take them all off. Oh, no, no, no. No, like I said, you're dealing with people who, and one I think I left out of who's at risk, who have been abused, who have a history of violence, who are substance abusers. This is a patient you're dealing with. And like I said, they are all throughout the hospital. Okay? So, you don't just take them all off. You have to let them show that their behavior is no longer hostile. Okay? When you go to your psych rotation, you will actually see the seclusion rooms. And they're scary. There's like this hard box. I call it a box. And you've got these bars to where you can be put in 4-point restraints. And I take the students, those that want to, it's not required, those that want to, and we tie you up just so you can see what it feels like to be in that room. There's no food, there's no water, there's no bathroom, there is nothing. And you are in supervision constantly, obviously. That is not what anybody wants to do to a patient. But we had a patient at the VA, guys, and he was losing it. Losing it. And he put stool all over him, all over the walls, and he was fighting. And they took him down. And he went into seclusion until his behavior could change. So, now that was in the psych area. And yes, you will get a chance to go to the psych areas. They're very interesting, very interesting. Some of you won't like it. I won't say that I liked it. I find it very fascinating. Very fascinating. And their stories are fascinating. Okay? And I don't know, have we got anybody in here in the military? In the military? You know, to talk with some of those guys who had been in combat and what they saw and what they went through and having to pick up bodies of their friends and things like that. I mean, I would be nuts. Absolutely wacko, you know. So, you know, we're not there to judge them. We're just there to try and help them, okay? Seclusion and restraints, theoretically, are the last resort. Use the drugs. Use those de-escalation techniques. You cannot be around these people. They're going to freak out. I mean, you're going to set them off even worse. You can't be. You have to be. I am in control here. You know, but also listen. Listen to what they're saying. Okay? That is so important. Let me pull up for you some of those therapeutic, and I'm pretty sure I put it on Blackboard, therapeutic communication questions. And guys, these are just some tidbits that I have found helpful in trying to eliminate some of your choices. And the seniors will tell you that the tidbits and the practice really help a lot. So those are things that I will look at. Okay, and yes, I will go over the PowerPoints. If you guys know me, I don't read them. Here's the lights. Is that better? Okay. Yes. So, when you've got those horrible, singers say horrible, they're horrible. Therapeutic communication questions. First of all, this is to help you eliminate options that indicate the use of poor therapeutic communication techniques. Now, does everybody, can I jog your memory about that in fundamentals? Any clue? Did Did you learn about open-ended questions?
Yes.
Okay. Things like that. That's what that's referring to. Okay, so, but it's poor. Poor is like giving advice. You remember, if you learned about what to do, you also should have learned about what not to do. Okay? We don't give advice. We don't judge. Right? It's a whole list of them. Eliminate options that tells the client what to do without regard to their feelings. And let me tell you, we are the world's worst. This is what you need to do. I know exactly what you need to do. You're angry over nothing. This is what you need to do. Take this medicine too. I mean, we're the world's worst. So, also questions that can provide a one-syllable response or yes or no. That is not the answer. It is not going to be the answer. Okay. Reasons. Why are you acting like that? Do you know? I thought you knew where you were. You're in the hospital. You can't act like that. I shouldn't have to ask a patient why you're acting this way. I mean, does it really matter? No, it doesn't matter. And that does not help the patient, okay? Okay, also eliminate options that apply disapproval of this patient's behavior. Okay, you hear it all the time at the nurse's desk. He's an alcoholic. What do you expect? He's an alcoholic. I mean, that's showing disapproval. False reassurance. You know, sometimes it's really hard, but please don't ever say, oh, it's going to be okay. Everything's going to be all right. Okay, unless, no, don't go there, okay? Again, you're interpreting the behavior instead of listening to what they're saying. I understand you're angry, and let's talk about this. I want to listen to what you have to say. Because the more I try to listen and work with you, hopefully I can find out the core of the anger and bring this person down. It's not about you. This is something the seniors always want to go for. Okay, it focuses on the nurse. No. It's about them. And them taking responsibility. It's not about you. You are not a fix-it-all. I don't care who you're dealing with. Okay? It's about them. They have to take accountability. Now, let's look at what to do. These are the responses that become the best answer. The responses that give the client time to think and reflect. In some questions, silence may be the best answer. Okay? Always go for the response that encourages the client to talk. Like I said, I see that you're angry. Let's sit down and talk about this. Okay? Those open-ended questions is what you want. Again, listen. Get them to describe what is going on. Okay? Responses that reflect that the nurse has listened. This is one of the best. Paraphrasing. Mr. Smith, I see that you're angry. Let's talk about this. I called you people an hour ago and I still haven't seen anybody. Okay, let me see what you are saying to me. You are calling out with your call bell, and you are feeling ignored because an hour has passed and no one came. How does that make you feel, Mr. Smith? Isolated, lonely? You don't care about me? All because a call bell wasn't answered. Okay? So sometimes getting to the core of a problem is one of the best ways to avoid hostile behaviors. I put this together because I'm a very, very visual person, okay? And I like the ears. It reminds me to listen, okay? Connect the dots. I'm paraphrasing, right? For clarity. Making sure I'm clear what the client is saying. The open door, open-ended questions, right? Again, I keep paraphrasing to get clarity of what my client is saying. And oftentimes, silence will get them to talk as well. If they feel that you care, you listen, and you can help in some way, okay? So those are just two little tidbits about helping you with therapeutic communication. And then next Wednesday, I've got this cool activity that will apply some of this, okay? But today, because time is short and sweet, always students are, I think there's one of these little funny things in here. Does it work? Sometimes. Okay. Oh well, no big deal. So these are the PowerPoints that you have. You will find that a lot of this I have already gone over. So if you listen, you've already got a gist of what this material is about. For example, who's at risk? All of this is right here. What does this person look like? As well as what do we do? And again, you'll find some tidbits. I put your page numbers down to reference your theory with that. I talked about the medications, and of course the last resort is restraints. Okay? Put you up some little tidbits about Joint Commission and their stand on restraints or seclusion. Again, you better be addressing the pain, potty, nutrition, and all that stuff. And documentation. Okay, you should have learned the fundamentals. If it's not documented, it's not done. So if that patient gets hurt while in restraints, okay, you could go to court for that. Okay. Also, to let you know, if a patient does hit you and it causes permanent loss or death, that is a sentinel event. Okay. Also, if a patient hits you, you can press charges against them. How many times in the healthcare environment, especially with nurses, do these things get reported? Very good. Very, very, as you can talk. Again, this is going back to what kind of guides how healthcare is laid out. This is just, again, things you can read over as to why we're trying to look at some different approaches to aggressive and violent behavior. Don't y'all love that? Isn't that cool? Yes, gangs are everywhere. everywhere. You go look them up. This is just, again, to jar your little memories about things we've talked about in class. Okay? So you can, as you're studying at home, again, you can kind of go through these and hopefully be able to remember this and answer the questions about this type of patient and what we're going to do. I also included this one just because these patients often have lack of support and ineffective coping. Their methods are based on a lot of them what they've been through. These are just some things we've already talked about. This is something I want you to be aware of. I've kind of alluded to the fact that there are hostile working environments in healthcare, not just because of patients, but also with coworkers and physicians. And it's very, very unfortunate that this type of thing is happening. You can see 80% go unreported. You may be asking yourself, why? Why is this such a problem? Well, if you stop and really look at what we do, you can understand why. We are in very emotionally charged environments. Shift work, of course, overtime. You're deprived of sleep and your own needs are deprived. So this is why, in fact, last week in IMC, with all the alarms going off, which is pretty much constant, and then the fire alarm goes off, I could feel my teeth clenching. You know, so just, a lot of it's the environment we work in is why there are issues with this. I will tell you guys what is the biggest problem with this. And this is alluded in that article if you get a chance to read that. Medication errors. Okay? Patient outcomes are effective when you are in a hostile working environment. So, what does this mean for you? When you go and interview for jobs, you better be looking at what kind of leadership is here. What do you see amongst the staff? Okay? Is the staff been here? Have the nurses been here a long time? Or is there turnover every month or every week? Do they seem happy? Do they feel like they have what they need to take care of patients? Because, guys, I will tell you this. Nurses do not leave their jobs because of a patient. That is not why they leave their jobs. We're all here because we have that desire to care for these people. It is other reasons, okay? So I encourage you all to start looking at where am I working? And is this a hostile work environment? Okay, how can you look at this? This has been a huge initiative in healthcare. This is a site you can go to. This was initiated in about 2005. The bottom line, when you're looking at your work environment, you should be able to see good communication, collaboration. In other words, you know, so-and-so sits down and does absolutely squat. That is not a team environment. That is not collaboration. That lends toward hostile working environments. And that's why people leave. I don't put up with this. Also, you are accountable, and you, in other words, I always tell my seniors, you're thinking nurses. You make good decisions. That's what keeps people safe, okay? Make sure you're in a place where they staff it. You know, I've heard of, nurses are, I had half the floor. Well, why'd you accept the assignment? You have a right not to accept that assignment. If you accept that assignment, guess what?
Your responsibility.
You're responsible now, and it is your license. And that's what you need to remember. This is my license. And that's what I always tell my seniors. This is your license. School's over. And so these are the things you want to be looking for. You want to be in a place, too, where your nurses are valued. Okay, I have worked in some awesome places. I've worked in some crappy places. Okay? And guess what? Do you think I lasted long at crappy places? Because I was taught the same thing. It's my license. I love nursing, but I'm not putting my license on the line because they can't get their act together. So, again, you want to be valued by your coworkers, by your physicians, but most of all, by your patients, okay? And that requires leadership, okay? People who are willing to go the distance to make this the best unit. At our very last 15 minutes, I have given you a little case. This is not something, guys, that you're going to see reflected in your read, okay? So, what have I done? Pretty much what you need is going to be right here, okay? So, I've given you a little case that you can look over that, for time's sake, I will start here. Now, conflict occurs all the time, no matter what. You guys have had conflicts in school, right? Sometimes I want you to know that conflict can be very good. It can cause change. It can cause people to be very creative and motivated and really think outside the box and to make it a better place, you know. And I hope when conflict arises, you verbalize it in an appropriate manner. So hopefully change can occur, okay? But conflict can also be a problem, especially when you do not have what I just talked about: good communication, good leadership, adequate staffing, to be valued for what I do and recognized for what I do, and making good decisions, okay? If that's not in place, this can then become very bad. Why? If you don't have what I just mentioned, and you'll see it in your little article, guess what we start doing? I don't want to go to work. I hate it here. I just hate it here. I ain't doing that. These people are crazy. I'm not going to do that. Negative, negative, negative. You all know what I'm talking about. And the conflict gets worse. Okay? These are just some little things about conflict. So, again, as you can see, without these in place, conflict can be, it's called bullying. And bullying is awful in nursing. Now, I'm sure each and every one of you have heard nurses eat their own. Right? That's called lateral bullying. It's people of equal status. Nurse manager who says, well, if you don't come in today, you know, I'm not going to give you that weekend off. That's bullying. Okay? That is bullying. Instead, work in a place that communication is there. Good leadership is there. Decision making. So if you say, I can't come in today, but I'll come in, I can come in the next 2 days, and the nurse manager should say, that'll be great. That'll be great. I'll try and cover today if you can come in the next 2 days. See how you can think outside the box and resolve conflict? But if these items are not in place, you're going to gossip, you're going to hate it, you're going to put people down, you don't sleep as well, you don't take care of yourself as well, right? What do you mean I can't go to the bathroom? What do you mean I can't eat lunch? I mean, come on, guys. How many people work 8 and 12 hours and don't eat? You cannot do that every single time. And granted, I know I've been there, right? I have been there. There are days that I'm just like, and I chose this because, but I come back the next day and it's better. You know, it's better. You're going to have days like that. That's just working with people. This is just how things can be responded. The best is, again, communication. Number 5, communication, really good leadership, all those things I talked about so that both parties are going to work it out. Questions for me? It's good to be back in class, as always. Try to be here Wednesday. I know some of you, your schedules conflict, but if for some reason